Hi everyone, so this video is going to be about hemodynamic monitoring and the hemodynamic parameters that we look at and that we try to get a sense of when we're looking at our patient's clinical situation. So you've already seen this hemodynamic monitoring setup, but essentially now we're going to talk about what do all these numbers mean on the screen and how do they relate to one another. So obviously in critical care, numbers in and of itself don't always mean something when they're all taken in isolation. We really want to be looking at trends to get a better clinical picture of our patients. So this is the setup that we would start with, and as you know, this pulmonary artery catheter, so the yellow piece here, would actually insert into a central venous catheter called a cordis, would be fished through, and this piece here, the end, would reach all the way into the pulmonary artery. So this would obviously be located in the neck, in the jugular vein, and would, as I said, finish off in the pulmonary artery. I'm just going to take it out for the purpose of the demonstration. So we've already talked about all the different lines, what they are. As a brief reminder, yellow is the pulmonary artery catheter, so it goes all the way to the pulmonary artery, so it's really the tip of our catheter. We have this syringe here. This is for the, it's labeled balloon. It's for the wedge essentially, so the pulmonary artery obstructive pressure, so we inflate a balloon to obstruct the pulmonary artery, and there's a sensor at the tip of that, closer to the left side of the heart, that actually gives us an indication of volume status in the left atrium, so it's very similar to the left atrial pressure. We have an auxiliary line here, which is we often call the fifth lumen, that we use for medication administration. Here we have our thermodilution catheter, so it just means that this connects to, it's essentially a temperature probe that we connect to our monitor so that we can see on the monitor our patient's temperature that's labeled directly there. So it is a core temperature. And then this blue line here is for the right atrium. So that finishes off in the right atrium. It's connected with the central venous pressure transducer to give us the central venous pressure. But it also has this cardiac output syringe here that we can use to measure cardiac output through thermodilution. So what does it mean, thermodilution? As a reminder, is that we will actually inject 10 milliliters of water, so essentially of normal saline. So if we were to follow this tube here, it would go all the way up here to a bag of normal saline. So this saline is at room temperature. There is also the possibility of having ice cold fluid to do this measurement, but in most areas we'll use room temperature fluid. So this is at room temperature. It's going to be injected into the body that has its core temperature labeled here on the screen. And depending on how much time it takes for that 10 milliliters of water to warm up, it'll give us an indication of cardiac output, so how well the heart is pumping. The quicker it warms up, the quicker the heart is pumping blood forward, therefore the better the cardiac output. And the slower it warms up means the slower the cardiac output is, so our cardiac output number will be lower. So if we really start with cardiac output and talking about how do we measure a cardiac output, one of the first things to know is obviously the normal range. So the normal range is 4 to 8 liters per minute. That's our normal cardiac output for an adult, essentially. So other variables that we have here that we're going to be looking at, as we do our thermodilution cardiac output, we always want to look at all of the other values at that time. So it really gives us a picture of, at that moment in time, this is what the patient clinically looked like when it comes to the hemodynamic parameters. So we'll do a combination of cardiac output, cardiac index, but we'll also go and measure the central venous pressure, the pulmonary artery pressure, and the pulmonary artery obstructive pressure all at once to get one big picture. So when we're looking at the CVP, just generally speaking, and every institution might do this a little bit differently, but the idea is that you want to again be measuring the central venous pressure at the end of exhalation. And you also want to be measuring it essentially in line with your QRS complex. So there is a way on our monitors in hospital to actually get lines, like on the monitor as we play with the buttons, to get lines that align along the QRS complex and across the central venous. So where the intersection of those two lines is essentially our measured central venous pressure. And we're taking the QRS complex that's right at the end of exhalation so that we don't have those intrapulmonary pressures affecting our central venous pressure. So the reason why we align with the QRS complex is actually because we want the pressure in the right side of the heart. So we actually want to ensure that all of the valves are essentially open between the right atria and the right ventricle. So we want that valve to be open, and that would essentially happen as there's filling right prior to systole. So just if you remember that electrical, the electrical image that comes up always happens before the mechanical capture. So generally speaking, if we're towards, the middle of the QRS complex, it means it's right before systole. So it's just before we mechanically have it happening. And so that's where, the valve is open, but it's filled with blood, and it's just about to close in order to go into systole and expel into the pulmonary artery. So the other value that we're going to look at is the pulmonary artery pressure. So that's in the yellow line. The pulmonary artery pressure is essentially the systolic and diastolic in our pulmonary artery. So it's very similar to our arterial blood pressure, just it's what's going on in our pulmonary artery. So the values are obviously much lower, and the normal would be 15 to 30 systolic over about ranges from like 5 to 15 about for the diastolic. So the way to measure is quite simple. We're able to actually pause this line here, and then we would go take the top of the curve up here, like the highest peak for the systolic, and then the lowest peak. So once you have your CVP measurement, one thing to remember is the normal for central venous pressure, and that's normally between 2 and 6 millimeters of mercury. But that's very dependent, so that's a healthy individual. So a low CVP would essentially indicate a low volume status, because a central venous pressure is essentially how much blood return is coming to the right side of the heart. And so if the pressure is low, it's usually related to a low amount of volume in the right ventricle. If our CVP is very, very high, there's a possibility that there is a lot of fluid into the right side of the heart, that there's a lot of venous return, and that our patients might be fluid overloaded. But there are other factors that may impact our CVP, so these are all things to take into context when we're assessing our patients and their hemodynamic status. So the other line that we can look at is the pulmonary artery pressure in yellow here. So the pulmonary artery pressure is essentially the same thing as our arterial blood pressure that we see down here in red. The difference is that it's obviously in the pulmonary artery, so it's the systolic and diastolic of the pulmonary artery. So the simple way to measure the pulmonary artery is actually that most monitors, if you just click on the waveform itself, it will actually pause, and you'd be able to go and align your cursor and measure. So you would measure at the top here of the waveform, the highest point, which would be the systolic, and then the lowest point down here would be the diastolic pressure. And so you would have your systolic over your diastolic. And that would be your measurement that you would take. And obviously, again, this measurement you would take at the end of exhalation. So at the end of expiration, right before your patient takes a deep breath and has air in their lungs, that creates intrapulmonary pressures that are elevated and would falsely elevate this.